Running an ambulatory surgical center demands absolute precision. Your clinical team is exceptional. Your OR turns are tight. And yet, despite that flawless execution and strong patient outcomes, administrators face a frustrating reality. Month after month, the revenue collected in the bank simply does not reflect the actual volume of work happening in the operating room. This disconnect has nothing to do with clinical performance. It is a highly specific, easily misunderstood medical billing problem, and for most facilities, it is significantly larger than they realize. The gap between what a center earns in the OR and what it actually collects is silently bleeding the industry. To understand the scale, we have to look at the macro level. The Centers for Medicare and Medicaid Services tracks these failures, and their 2024 fee-for-service data reveals exactly how much money is slipping through the cracks. In 2024, the improper payment rate across ambulatory surgical centers hit 14.7%, a projected industry-wide loss of $656.3 million. Breaking that figure down, one root cause dominates. Insufficient documentation accounts for 58.8% of missing funds. That is a massive communication gap. These statistics do not represent random, unavoidable mistakes. They are systematic, repetitive breakdowns committed by in-house billing teams, claim after claim. The failure stems from the structural mechanics of ASC claims. Ambulatory billing requires facility-specific CPT codes, which define the exact procedures performed, and distinct modifier rules. Treating these claims like standard physician or hospital outpatient billing guarantees errors. The first major friction point is uncaptured implant charges. Failing to log device charges at the precise point of procedure creates a quiet but massive revenue bleed that end-of-month reconciliations rarely catch. This bar chart illustrates the drop-off. If a center running 200 to 500 procedures a month has a 40% failure rate in device capture, the gap between procedures performed and revenue collected eliminates between $40,000 and $240,000 every single month. The second friction point lies in complex modifier rules. Modifiers tell payers that a procedure was altered, like a bilateral or discontinued surgery. Missing or incorrect modifiers consistently rank among the top 5 reasons an ASC claim is denied. The third friction point is the expanding prior authorization burden from private insurers and CMS demonstrations. Without perfect tracking, facilities face canceled cases, delayed patient care, or zero chance of reimbursement. The penalty for hitting these friction points is steep. Reworking a denied claim costs a center between $25 and $118 in administrative time. Because of that heavy cost, approximately 50% of denied claims are simply abandoned. Generalist billers operating standard workflows are simply unequipped to survive the unique pressures of the ambulatory surgical environment. If we shift our focus from the clinical claims to back-office administration, we have to challenge a common assumption. Most operators look at their salary line and think they know what their billing department costs. They do not. Once you factor in payroll taxes, health benefits, and software licensing and paid time off, a single full-time in-house biller actually costs a facility between $55,000 and $75,000 annually. Operators know this as the staffing spiral: hire, train, and inevitably lose them to higher-paying opportunities. Per MGMA data, this loop carries a massive penalty. Replacing a single staff member costs the center $25,000 to $30,000. Beyond the hard dollars, there is the invisible cost of turnover. The institutional knowledge of specific payer mixes, local notifier rules, and physician documentation habits walks right out the door with the departing employee. The standard in-house billing model operates as a compounding financial liability. It actively limits a center's ability to scale its operations. Top-performing ambulatory surgical centers are solving this crisis. They are not doing it by hiring more generalist staff, but by entirely offloading the process to specialized partners. The core of this new infrastructure relies on dedicated billing specialists carrying specific AAPC and AHIMA surgical credentials. Crucially, these experts work directly inside the facility's existing electronic medical record system, maintaining continuity. Modern workflows also deploy AI, but not to replace human billers. Instead, predictive smart routing assigns high-priority claims first, and automated audits catch missing codes before submission, augmenting the human experts with machine precision. By combining credentialed human expertise with AI-augmented tools,
These specialized teams suppress error rates and maintain them consistently below 1%. High-performing centers secure their bottom line because they treat the pre-surgical revenue cycle and charge capture with the exact same rigor as their clinical workflows. Staffingly provides the specific execution for this high-performance model. When a center partners with them, the theoretical benefits become practical financial math. This ledger shows the exact cost comparison. Instead of the towering costs of an in-house employee, Staffingly provides this dedicated infrastructure for a flat $399 per week per seat. That structure completely eliminates training overhead, benefits load, and turnover costs. Integration is rapid. Facilities are typically operational and processing claims within 14 days. The Staffingly team seamlessly operates within the center's existing software, whether that is Epic, Athena, or eClinicalWorks, or dozens of others. Centers see measurable return on investment within 60 days. To verify those results before committing, facilities can use a 2-week risk-free pilot, where a true performance baseline is established right inside their own billing keel.